Bismillah. Percubaan 1, 2, 3. Boleh dengar ya? Dah start dah ni. Okay, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh to all my IIUM brothers and sisters. Selamat pagi Jumaat. InsyaAllah hari ini I would like to welcome you to our second long overdue health talk series. Actually, we had the first one during the COVID-19, right after when it's declared as a pandemic. So we had the first session with Dr. Siti Masitah Jamaluddin, our Chief Medical Officer. And afterwards, following that, we think that the health talk is a good initiative for all IIUM staff and as for us to be aware of our health conditions. So today we have Prof. Muhammad Aznan Mat Aris, Head of Department Family Medicine from Kulliyyah of Medicine, Kuantan. And again, we are going to talk about the unseen enemies, but this time it's about the famous health disease in Malaysia, especially. It's on the diabetes, hypertension, and also high cholesterol. So I think without further ado, I would like to invite Prof. Dr. Muhammad Aznan, as I think he had a lot to share with us today. We had 3 topics to be covered. I hope everyone could benefit something from it. Okay, inshallah. Welcome, Prof.
Welcome. Assalamualaikum warahmatullahi wabarakatuh. Thank you to chairman. Okay, like to share the screen. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala anbiya'il mursalin sayyidina Muhammadin wa ala alihi washabbihi. Okay, first of all, I'd like to thank to the organizer, to the MSD for inviting me to actually share my experience for in this IIUM health talk. We start actually the second IIUM health talk this time. Actually, this is good. Actually, it's by using with this pandemic COVID. Actually, it's good. Actually, we can share our a bit on health issue amongst our IIUM committee. Okay, without further ado, I'd like to start to share my slide on these topics. Okay, all right. Okay, okay, we go to the topic of today is about the 3 enemies. Which topic given to me is about the diabetes, diabetes mellitus, hypertension, and also high cholesterol. First, I'd like to this slide actually mainly I prepare is based on the 3 guidelines which have been produced by our Ministry of Health. The first is the guideline on the management of type 2 diabetes. This one in 2015. The latest supposed to be by this year or maybe early next year. And another one is the guideline for the management of Dyslipidaemia in 2017. And another one is the management of hypertension, also in same 2017. And the things about this slide, also I combine a few on the slides which given by me before on the few workshops. And also from actually share a slide from the Associate Professor Dr. Mazuki, our endocrines. A bit of piece on about diabetes. Okay, so these 3 enemies, diabetes, hypertension, and also dyslipidemia, is a chronic illness for these 3 diseases, and also well known as we call as non-communicable diseases. I think before I go further in all of these 3 diseases, I will discuss a bit on what is non-communicable disease, the main topics. Okay, actually, non-communicable disease is known as chronic diseases. These tend to be of long duration, and are the result of the combination of could be from genetic, psychological, It's metabolic, environmental, and also behavior or lifestyle factors. And a disease that cannot be transmitted by pupils, vectors, or contaminated objects. So metabolic risk of NCD, such as high cholesterol, that what we discuss after this, and high blood pressure, and also high sugar. And the other things are details about the cholesterol, but the low HDL cholesterol, high TG, and don't forget about the metabolic risk NCD is about the obesity. So this NCD are responsible for about almost 71% of all death worldwide, which equivalents to 41 million people die. This one data in 2017, where the five common the major cause of death is a cardiovascular disease, which relate to our topic this morning on diabetes, hypertension, and also cholesterol. Another is a chronic respiratory diseases, cancer, diabetes is specific, and also mental health disorder. So actually, the NCD, they have a few risk factors that can be modifiable. It means that we can actually manage, or we can modify the risk factor to reduce to have these NCDs. The first thing is about tobacco use. Those who are smoker actually risk to get all of these diseases, the cardiovascular, the cancer, diabetes, and also chronic diseases. Those who are physically inactivity. This maybe we need to discuss further about this one. Physically inactivity, this means that you are not doing enough exercise, daily exercise, or numbers of exercise, which actually can relate to the cardiovascular disease, cancer itself, and also diabetes. And unhealthy diets, this is what the risk factor also relate directly to the cardiovascular disease, cancer, and also diabetes. And last about the harmful use of alcohol. Okay. In global burden, I mentioned just now, about 41 million die each year because of the NCD. And 85% of this 41 million are seen in the low and middle income countries, which including our countries, Malaysia. And about a third or 33% of these 45 million deaths attributed to NCD globally each year are premature. I mean, those who have died less than 75 years old. And probability of premature death in developing versus developed country is about 2 in 1. It's more in the developing countries compared to developed countries. So the burden of this NCD is increasing globally, which is years about 50 million on all NCD deaths occur in the age of 30 to 70s. It's a premature, 30 to 70s. Where the most common is where the highest is the cardiovascular disease, with about 80% all premature NCD death, followed by cancer, respiratory disease, and diabetes, where the topic that we discussed after this, 1.6 million. And increase due to cardiovascular disease also increased for the last 10 years. You can see the pattern from 2007 to 2017 is increasing trend of globally mortality due to CVD, cardiovascular disease. And in ASEAN regions, it's almost similar. Lead by the highest is cardiovascular disease or deaths, and followed by the respiratory disease, cancer, diabetes, CKD, and also mental health disorder. About Malaysian landscapes, as we know, our population in 2017 is about 30 million. And how about our population mortality due to NCD in Malaysia? It's same also. In 2016, based on the National Health Survey 2016, the cardiovascular disease is the main or 35% cause of death in NCD Malaysia is CVD, and followed by the cancer, respiratory disease, and also diabetes, about 3%. And if you see the cause of death in Malaysia in 2007 versus in 2017, and even actually last year also, ischemic disease is still the first ranking of the cause of death in Malaysia. And if you can see the risk factor attribute to NCD in Malaysia, the biggest contribute in terms of disability life years in our country is a high blood pressure. Those who have hypertension, we follow with diabetes, high BMI, it means overweight and obesity, and also high cholesterol in both males and also females. This is a risk factors on the cause of highest risk factor of the NCD in Malaysia. Okay, back to our topics. Why to these three topics, three enemies? It's important we need to discuss. We need to update ourselves. We need to increase our knowledge about diseases. Because these three diseases, actually we're a bit worried because as we mentioned earlier, I mentioned earlier about the NCDs, the CVD, cardiovascular disease has been the leading cause of death in Asia for over decades. And the common cardiovascular risk factors we mentioned is a dyslipidemia or high cholesterol, high blood pressure or hypertension, diabetes, smoking, overweight, eh? overweight and obesity. And all of these risk factors are on increasing trends for the past few years. It's more than 10 years, it's increasing trends. Okay, we go to the first topics about diabetes. I will talk one by one and try to combine later on the management for these three diseases, mainly for the NCDs. Okay, overview of diabetes. We can see that according to the last update from WHO, is estimated almost 422 million people globally were living with diabetes in 2014 compared to 108 million in 1980s. And they also estimate that it will rise to 640 million in 2040. So another 20 years based on the IDF or International Diabetes Federation in 2015. And the global prevalence of diabetes also showed double increments in 1980 from 4.7 to 8.5% in adult populations. So if you see that worldwide, it's a global emergency where the increasing numbers of diabetes worldwide, whereas they estimate in 2040, another 20 years from now, is about 642 millions in the global worldwide we are diabetes. Sorry, about the Southeast Asian, also in 2040 is about 140 billions in Southeast Asian are diabetes. Okay, in terms of numbers of still undiagnosed, for numbers of age of 22 to 79 years old who are undiagnosed in 2015, same quite numbers of patients still undiagnosed. Mean they not came, or maybe they don't have, maybe they have symptoms but they're not coming to be diagnosed by the doctors. But this number actually increasing for the past few years. Okay, same also the proportions of patients who die for diabetes before the age of 16. Also, we can see that in our country, it's almost this one about 40 to 60%. It's a die because of diabetes age less than 60 years old. And we see diabetes around the world. The prevalence in 2015 is about 1 in 11 adults has diabetes, which will increase in 1 in 10 adults will have diabetes in 2040. So you are, if you're around 10 adults, one of them is the diabetes. Okay, the cause of the diabetes is actually increasing. It's almost 11% worldwide healthcare expenditure for diabetes. And how about our burdens of diabetes in Malaysia? We see that the trend and projection by 2020, and actually the diabetes also increasing. And we can see the prevalence of diabetes in Malaysia. The overall prevalence of diabetes among adults of 18 years and above was about 17.5%. This one based on the National Survey 2015 to 16, which risen from the 15.2% in 2011 and 11.6% in 2006. It's increasing in Malaysia. We see the chart, this one. Last 5 years is 70.5, supposed to be this year. They will have another national health survey. We foresee that it will be increasing in trend in diabetes in our country. This one for 18 years and above. If we see those prevalent diabetes for age patient 30 years above, is on last 5 years is about 22.5% the prevalence. And among this one, we can see that another one, this one for total, but for those who undiagnosed, the green one, and this one is known is about 10%, undiagnosed is 11.9%. So in other words, that amongst almost half of it, total diabetes are actually undiagnosed. Or in other words, you can say that 1 in 2 adult with diabetes actually is undiagnosed. Okay, what is the risk and complication of this diabetes? As mentioned, that's what the key management of cardiovascular disease actually is mainly about the cardiovascular disease, about the coronary heart disease. It's mean about the heart attacks, and that is about the strokes, and about the heart failure, and also about the peripheral artery disease. What we talked just now about the CVD is about mainly about these four disease, coronary heart disease, strokes, heart failure, and peripheral artery disease. And in type 2 diabetes, as the major and also independent risk factor for both the microvascular and also macrovascular complication. So if you see that those who have diabetes, the long-term complication, they may have a macrovascular, mean they can have a stroke, they can have a coronary artery disease, and for the macrovascular and for the microvascular and peripheral disease, they may have a kidney problems, chronic kidney disease, and also they may have a diabetic retinopathy, eye problems. And these are a major and risk factor to those who are type 2 diabetes, also type 1 diabetes itself. So the facts on diabetes. Diabetes is a major cause of blindness, and also kidney failure, heart attack, and stroke, and also lower limb amputations. In diabetic patient, the most common debilitating complication of peripheral neuropathy, of which 70% affect the foots. If you see that clinical impact diabetes, 2 to 4-fold. If you have diabetes, you have a chance 2 times to 4 times increase for the cardiovascular mortality. You may have a coronary artery disease, coronary artery heart attacks, and the diabetes also the leading cause of new case of end-stage disease, and the diabetes also the leading cause of new case of blindness in the world age adults, and diabetes also the leading cause of non-traumatic lower extremity amputations, and they get diabetic foot and low and it's still not controlled, then can lead to the amputations. Okay, the risk of deaths due to cardiovascular disease or heart disease increased about 2 to 3-fold in men with type 2 diabetes. This based on the quite old articles on this one, study on a few study, and they compare among those non-diabetic and diabetics. The relative risk of heart disease when you have diabetes is increased to 2 to 3-fold. We can see here on this study. Another Paris study and Helsinki study also same say once you got diabetes, your chance to have a death due to heart disease increase about 2 to 3-fold. Same also another study by the Freeman study shown that once you have diabetes, 2 times increase in men with those with non-diabetes, and in women it increase about 2 to 5 times risk to have a cardiovascular disease once you got diabetes. So in other words, that once you have a coronary, or we call it cardiovascular disease, mainly about the atherosclerosis in diabetes, it causes about 80% of all diabetic mortality, and 70% of them from the coronary, or we call coronary is the heart, atherosclerosis, and 30% from the cerebral or peripheral vascular disease. So in other words, that 80% of all diabetic mortality is from the coronary is heart, from the heart disease, and 25% from the stroke and also peripheral vascular disease. It costs about more than 70% of hospitalization for diabetic complication, and more than 50% of patients with diagnosed type 2 diabetes have a coronary heart disease. So that's how actually complication of this diabetes. So go to the natural history of diabetes. How actually this diabetes develops. Maybe a few of us actually either we already have diabetes, or maybe we have a risk of diabetes. We can see that before diabetes onset, at 0 year here, before you got diabetes, before diabetes been diagnosed, you may have actually last another 15 years back or before you are in the pre-diabetes. During this pre-diabetes, sometimes we doesn't know, we don't have any symptoms. That unless if you come for the medical checkup, if you have a risk, then you get known that you have pre-diabetes, or maybe you've got diabetes. As in early stage, as insulin resistance rise, there is a compulsory increase in insulin secretion and glucose level which remain normal. As the beta cell dysfunction worsens, insulin, we can see that the insulin secretion will be false, and the impaired glucose tolerance and hyperglycemia become apparent, and over type 2 will develop after that, after at the 0 or 5 years. We can see that the pattern of the fasting, the below is a glucose level is increasing. After 5 years post diabetes onset, they will increasing trend. If 10 years, will increasing. So this glucose level, both pre and post prandial, post fasting or post taking the foods, increase steadily as the individual progress from normal glycemic to impaired glucose tolerance and finally to type 2 diabetes. So the risk factors to have diabetes, actually the first thing is the overweight and obese. Those who have first degree relative of diabetes, it means their fathers, mothers, or maybe the siblings who are diabetes have a risk to have diabetes. Those who have history of cardiovascular disease, those with hypertension, those with pre-diabetes, they will tend to develop diabetes later on after 5 to 10 years. And those who have dyslipidemia or high cholesterol, those who feature of insulin resistance, for example, it's a big baby, it's a big baby is more than 4 kilograms, it's a previous GDMs, gestational diabetes. Those patients who have a polycystic syndrome have a risk to have diabetes, and those who have physical activity, and those who some medication, for example, antiretroviral therapy or atypical antibiotic drug may also risk to have diabetes. Okay, in general about diabetes, we usually say that commonly classified diabetes, we have a few types that commonly most of them knows about type 1 diabetes and type 2 diabetes. But don't forget, we also have a gestational diabetes, which diabetes occur during pregnancy, and also diabetes occur for other causes, due to other causes. Okay, for other causes, for example, they have a Mohd, disease to exocrine pancreas, and due to the drug causes. For the type 1 diabetes, usually due to its beta cells in the pancreas destruction, will lead to the absolute insulin deficiency. Most of the type 1 diabetes, they have the autoantibody, and also present of the pancreatic isolate beta cell antibody, and also present of the GADA, this is glutamic acid decarboxylate autoantibody. And sorry, in type 2 diabetes, usually is caused by insulin resistance and relatively have the insulin deficiency. And whereas in GDM or gestational diabetes is glucose intolerance during pregnancy, due to metabolic and also hormonal changes. And other specific types I mentioned just now, Mohd, this one, there's a few other tests that we will need to do. Actually, they have another one type diabetes, from type 1, type 2, some call as type 1.5 or 1.5 diabetes. Is also known as latent autoimmune diabetes adult or LADA. In this type, LADA is the presence of the autoantibody, same like in type 1, presence of GADA, and the phenotype same as type 2 diabetes adenosis. Whereas the type 2 diabetes patient, usually they have overweight or obesity, which similar in this LADA classification of diabetes. But over the time, it's similar to the type 1 diabetes. Okay, in other words, what we need to know about the classified diabetes, mainly about type 1, type 2, the others maybe lacks to the endocrines, the doctors to know to discuss details about the other type of diabetes. Okay, this type 1 is mentioned as now, type 2. Mainly is about in type 1, they occur early during childhood, or usually less than 20 years old. And type 2 diabetes frequently after the age of 30s. And the patent onset is usually symptoms develop rapidly, whereas type 2 diabetes, usually symptoms of diabetes appear gradually. That's why most of the type 2 diabetes don't have symptoms until gradually they have later on after a few years. And genetic predisposition usually more common, both moderate in type 1 and very strong type 2 diabetes. With body weights, usually in the type 1 diabetes, they have normal body weight, whereas in type 2, overweight or obese. And in the plasma insulin release, if you know, as we discussed, the type 1 usually they have low or absent insulin secretion, whereas type 2 they have a normal or high. But because of the sensitivity is reduced in type 2 diabetes, that's why they have a diabetes. And acute complication both different between both the type 1, type 2, and also the treatment. Usually for type 1, they require insulin. Whereas type 2, sometimes we will advise together with diet, exercise, and also medication, the oral one. But later on, maybe they will need also insulin still not control. Okay, what's the clinical features of diabetes? 50% of diabetes are asymptomatic at early stage, which this early stage is discovered on routine investigation. That's why it's very important to do the screening for diabetes. In those who have symptom, the acute presentation, usually in young patients, usually those with type 1 diabetes, and it's a brief about 2 to 4 week history of symptom like polyuria. Polyuria is a pass lots of urines, and thirsty, they feel dahaga lots, due to fluid electrolyte loss, and they have a weight loss. Uh, they may have this triad or these three symptoms, or maybe they don't have. They just got maybe just a lethargy, they feel weak, and after that, maybe they just weight loss, they don't much have like polyuria, pass lots of urine, or very thirsty. It depends to the patients. It's individual. Some patients have all of the symptoms, some just got one or two, some don't have the symptoms. Okay, in subacute presentation, maybe over several months, all the patient, other than polyuria, thirsty, weight loss, tiredness, some their pruritus, itchiness, and also infections had the genital organs, vulva, and also the bronchitis. Or maybe some of them don't have the symptom, they presented with the complications. 30% type 2 diabetes have complication diagnosis, for example, due to skin infection, or maybe they present a blurring of vision, they have a cataracts, or they have some retinopathy or eye changes, or maculopathy, or maybe they feel a tingling and numbness of the hands due to polyneuropathy, complication of diabetes, or maybe they have impotence due to autonomic neuropathy, or some of your patients may present with the cardiovascular disease, they have coronary artery disease, they got a heart attack, or they got a stroke due to macrovascular disease complication of diabetes. This is a complication. This is the symptom of diabetes. 50% don't have symptom, 50 have symptom. Either it's an acute symptom or subacute, or maybe they present with the complication for diabetes. Okay, in terms of diagnosis, how actually diabetes been diagnosed? Diagnosis of type 2 diabetes must be confirmed by measurement of venous plasma glucose. It means you have to take blood. You have to take blood, you have to draw blood, and by take blood, you can know by ordering the venous plasma glucose or A1C level. Previously, I think more than 20 years back, sometimes we check the diabetes by using urine. But urine is not confirmed. Once you have a sugar in your urine, we may need to do a further test, may need to take the venous plasma glucose. You have to take a blood for that one. In asymptomatic individual, patient who have symptoms just now, they have a polyuria, they have thirsty, weight loss, or maybe they have the symptom of tingling and numbness. They need one abnormal blood glucose value as diagnostic. But those who are asymptomatic, don't have any symptom, they need two abnormal glucose are required to diagnose diabetes. So what are these results? I want to share for all of you for the benefit that if you do a test, you know, okay, if I got this test of random plasma glucose, if your random plasma glucose is more than 11.1 and more, you are abnormal for the blood glucose. But if you have the fasting plasma glucose during fasting, your result is 7.0 and more, you are a diabetes range. And if you do the oral glucose tolerance test, OGTT, for 2 hours postprandial or post glucose, the result is 11.1 millimole, is also is a diabetes range. And if you do the A1C, the A1C, your value is more than 6.3% and more. Okay, if like I mentioned earlier, if you have a symptom, you need only one of these results abnormal. For example, you have a symptom of thirsty. or lethargy, your random plasma glucose, when you send the random plasma glucose, the result is 12. So you are confirmed to be a diabetes. Uh, but if your result turn back in between, for example, your impaired fasting or your fasting plasma glucose is between 6.1 and 6.9, and you may be labeled as a pre-diabetes. Um, and for the oral glucose tolerance test, if you do the OGTT, the result of the 2 hours postprandial between 7.8 to 11, you also be labeled as a pre-diabetes. And for your A1C, if you got elevated, about 5.6 to 6.2%, you are at the range of the pre-diabetes. Okay. I show you this based on the mentioned guidelines about the screening type 2 diabetes in symptomatic individual. Those with symptom, you have to go to the clinics, to health center in the Gombak, or to the family clinic in the Kuantan. They will draw bloods, the venous plasma glucose. Either you are fasting, or you are not fasting. Not fasting because random. So in fasting, the result, if the fasting is less than 7, but you have symptom, less than 7, so we will proceed with the oral glucose tolerance test. This OGTT is sometimes we call it a minum air gula. So minum air gula, this is the OGTT. So the OGTT, they will give you appointment another next 3 days. Or maybe if you have normal last 3 days diet, maybe the next day will give you the appointment to do the OGTT. In this OGTT, they will draw you a blood when you come after fasting, about more 8 hours and above. You come to the clinic, they will draw blood for the 0 hours of fasting, and they give you a glucose, 75 grams of glucose in 1 cup, or 250 to 300 ml water, and you need to finish it within 5 to 10 minutes. And after that, you rest for about 2 hours, they will draw another blood. That what we call as 2 hours postprandial or 2 hours post-glucose test. And then if you are doing just now, fasting is more than 7, you will symptom, you are confirmed type 2 diabetes. Similar to the random, your random is 11.1 more, you are confirmed as type 2 diabetes. And those who are at level less than 11.1, they will proceed with OGT test, oral glucose tolerance test. Okay, sorry. Okay, in those who are asymptomatic, this means don't have symptom. Ideally, usually we do the capillary first, capillary, or we call it a glucometer. That's why sometimes if we do the mass health screening, or sometimes we do a medical checkups, open the counter, whatever medical checkups, regardless either you are fasting or non-fasting, we take the cut point of 5.6, right? For example, you go to the shopping mall and then they have a medical checkup, you check your glucose using the glucometer. Your value should be less than 5.6. If your value is more than 5.6 and above, we will advise, or maybe the counter, or maybe the medical checkup, the doctors or the paramedic during that time, we advise or maybe refer you to the nearest clinics to do the venous blood glucose, venous plasma glucose. Similar like just now, either venous is fasting or is it random. Those who are fasting, the result to be similar just now, 6.1, and below is normal. 7 and more is you may have to repeat for another second blood glucose. Because for asymptomatic, they need 2 and normal blood glucose, you confirm diabetes. But if you are at risk, usually those at risk, sometimes we will directly refer or maybe give appointment to do the oral glucose tolerance test directly. Because in the OGTT, they have 2 tests. One the fasting, another one 2 hours postprandial glucose. For example, if the individual have a diabetes range for the fasting 7 and more, and 2 hours postprandial glucose is 11 point more, they are confirmed diabetes, even they don't have any symptom. Okay, all right, just briefly about that one. Okay, whilst in the pregnancy, maybe those who few of us actually already has been asked during their pregnancy to minum air gula test, especially those who at risk. The result for the oral glucose test for diabetes actually during the pregnancy, a bit more tight. In other words, that if your result for your fasting is 5.1 and above, or your result of 2 hours post glucose is 7.8 and above, either one, you got either fasting only or 2 hours post glucose, either one or both of it, you'll be labeled as the gestational diabetes. Usually this obesity or OGT is done at the 12 to 14 week gestation or pregnancy of mother with risk factor. And those who are normal, they will repeat at the 28 to 30 week gestation. So either one, in the gestational diabetes, either your fasting or your 2 hours post glucose is abnormal, we label as a gestational diabetes, and they will proceed with another test afterwards. Okay, who actually should be screened for diabetes? Sometimes you say that, yeah, you can sihat, tak ada masalah apa, okay. But you need to know when that you need to screen for diabetes. Those who need to screen diabetes are first, for sure, any individual who have a symptom such as diabetes must be screened. Please come to the clinic to screen for diabetes. But those who are asymptomatic, most of them are asymptomatic. More than 50% of the patients are asymptomatic, but they have a risk. The first is about the risk, they are overweight. Overweight, if you calculate your BMI 23 kilogram per meter square or more, or maybe you're already obese, you need to come for the screening. Or the waist circumference for the woman is more than 80 centimeter or more than 90 centimeter for men. 90 centimeter ni is almost 36. If you pakai tarik pinggang tu, seluar is about 36, 37, 38, around that inch. Kalau your trousers, so it means you already have a central obesity. And additional the risk factor, for example, you have dyslipidemia, it means that asymptomatic but you have overweight, or you have central obesity, and you have a cholesterol, high cholesterol, or you have history of cardiovascular disease, you have hypertension, you have IGT, or you have siblings or your fathers or your mother is diabetes, you need to screen for diabetes. Other clinical conditions that related to severe obesity and also active significant, and or maybe you are overweight and you are physically inactivity, you also should be screened for diabetes. And women with a polycystic ovarian syndrome and pregnant women for sure will be screened for diabetes. And the rest is for the children. Okay, that's about the first about the diabetes. I go to the second about the dyslipidemia. Dyslipidemia or high cholesterol. We can see that the prevalence of high cholesterol, those 18 years and above, from 2006 to 2015 National Health Survey is increasing. It's almost 50%. I think if they do another one this year, they're not going this year, maybe next year, so about the National Health Survey, it will increase more than 50%, or maybe 60%. 60% of amongst Malaysians have a high cholesterol. And if you see the cholesterol in those age 30 years and above, in last National Health Survey, the numbers, the prevalence already about 56.8%. So I think for this 2020 or 21 National Health Survey, because every 5 years they will do another one, the prevalence of cholesterol in those 30 years above will be reaching almost 60 or 70%. So among us all here, maybe we can, maybe a few of you already have a high cholesterol. Maybe we're not aware or never been checked. Okay, why is important about this cholesterol? As we mentioned about this based on national, this point NGM's journals about when you have high cholesterol, it will develop, increase develop of arteriosclerosis, where increasing of cholesterol will lead to late-stage arteriosclerosis. You will have more on the part of the arteriosclerosis, we have a coronary artery disease, and also you may have a stroke, also peripheral disease just now that we discussed. So important to know about your cholesterol level. So in Malaysia, we call as dyslipidemia, sometimes we call as hyperlipidemia or hypercholesteremia, is all same. So in this slide, we discuss about, I mentioned about dyslipidemia. So dyslipidemia is referred to the following lipid levels. For example, if when you check your cholesterol level, if the total cholesterol is 5.2 and above, or another one, they have a numbers below that is a high density lipoprotein cholesterol, HDL. They have two values. Usually we make cut point for males if less than 1, or for females less than 1.2. And HDL we want a bit higher because HDL is also known as we call it as a good cholesterol. Is you have higher HDL, actually there is a more protective for you to prevent to have a coronary heart disease. Triglyceride, another one, if you have triglyceride 1.7 millimole per liter or more, you have a dyslipidemia. And the other one is the low density lipoprotein cholesterol at their level, but it will depend to your patient or your individual cardiovascular risk. We share this. Okay, if you talk about dyslipidemia, dyslipidemia usually is classified based on the causes. Either the causes is due to primary, usually due to genetic causes. That's why some few have a quite normal body weight, everything, but they have quite high cholesterol. This is familial hyperlipidemia, due to genetic causes. Maybe the parents or maybe the siblings have a high family hyperlipidemia. They have quite high cholesterol. This one, even they have normal size, body weight, everything, or maybe they due to the secondary cause. Dan kebanyakan most of us due to secondary cause. The first thing is about lifestyle factors. Because of a few, those who have the alcohol, those who have taking the saturated fats and trans fats very high. Those who are smoker and do a physical inactivity due to lifestyle factors, they can cause this dyslipidemia. The other one is due to metabolics or endocrine factors. For example, due to thyroid, they have hypothyroidism or Cushing syndrome, or also they may have insulin resistant states such as maybe they have diabetes. They will increase actually to chance to get dyslipidemia and other metabolic syndromes. And other causes, secondary causes of the dyslipidemia due to renal, kidney, like nephrotic syndrome, and to liver due to polycystic liver disease, and due to some drugs. Some drugs you taken may also lead to increase your cholesterol. Okay, back to the stratify of your cardiovascular risk. We can see the risk of cardiovascular risk based on a few factors. Just now, to determine your level for LDL cholesterol is based on your cardiovascular risk. For those who have very high risk, mean that individual who have established cardiovascular disease, either they have history of coronary heart disease, or they have history of stroke or peripheral vascular disease. It means they have established CVD. It means they are very high risk. Or patients who are diabetes with presence of proteinuria. This means they have some kidney problems, renal impairments, or diabetes, they have diabetes, or with a major risk factor, such the patient have diabetes and he also a smoker, and also hypertension. This is a major or because it's very high risk. The other one, those who are have a CKD or chronic kidney disease of stage 4, stage 4 and above. Stage 4, stage 5 is a very high risk. That is high risk. After very high risk is high risk diabetes without any target organ damage. Those with a chronic kidney disease but stage 3 only. That's why some we see a doctor, they say, your value of kidney, you are now have a mild or stage 3 kidney failure. Sometimes we don't know, stage 3, what, stage 4 and stage 5. There's a 5 stage, stage 1 and stage 5. And that is high risk, those who have very high level of individual risk factor. For example, the blood pressure is high and the LDL cholesterol is more than 4.9. And multiple risk factor based on the Framingham cardiovascular risk score. And the other one is intermediate and low risk, those who have very low score, Framingham score, but 10 to 20% or less than 10%. Okay, what is the Framingham score? Framingham score actually is based on your age, based on the gender mainly, and after that based on your age, your value of your cholesterol, mainly HDL cholesterol and total cholesterol, and your blood pressure, and either your diabetes or your smoker, we will calculate the risk, the points. Based on that point, we will see what is your risk. Either is a less than 10%, very low, intermediate, 10 to 20, or more than 20%. This is what we discussed on the previous slide. Okay, the target LDL cholesterol level based on the low risk. For example, do a low risk or intermediate, the target should be the LDL is less than 3. And once your LDL cholesterol more than 3.5, the doctor will start the medications. And high risk, the target is less than 2.6, and very high risk. You will have already established cardiovascular disease, or you have diabetes with proteinuria, or you have diabetes with a smoker. The risk is you must target LDL cholesterol is about should be less than 1.8 millimole per liter. Or you must have reduction less than 50% from the baseline. Okay. Okay, when we want to do a screening? Screening for cholesterol. Bila nak check your cholesterol level? Screenings mean that based on the latest guideline, this screening cholesterol, you can do either is a fasting or non-fasting. There's some bit difference, but in terms of the difference, not much. You can do either random cholesterol or you will be fasting. But if possible, if you're doing the fasting, you can do other tests, for example, fasting blood sugar, and also doing together with all the cholesterol. But it's not this must be in the fasting. Okay, what the test that we do in the cholesterol screening, the best you have to do all the complete lipid profile, the total cholesterol, the LDL cholesterol, HDL, also the triglyceride. When want to screening, based on the Ministry of Health guideline for the CVD screening, all patient age 30 and above, we have to do the screening, the screening the cholesterol, and also the other screenings, the blood pressure, and everything, so diabetes to be screened. Then yearly screening. For example, if your result is normal, you have to do it yearly. But if you're individual with high risk of CVD, you need to start earlier. At the age of 18 years above, you to start to screen for your cholesterol. For example, maybe you have family history of premature cardiovascular disease, or you know that your one of your siblings have a familiar or high cholesterol, or maybe you have a Mellitus syndrome, or you have diabetes or obesity. You should screen earlier, not tak payah tunggu 30 years old. Less than 30 years old, so you can come to screen for your cholesterol level. Okay, next the last is about the blood pressure. So hypertension, high blood pressure actually highly associated with other concomitant disease, stroke, heart failure, chronic renal failure, heart disease, and also with diabetes mellitus and also obesity. We can see that a few on the UK-PDS study on blood pressure and myocardial infarction. When the increasing of your systolic blood pressure, the adjusted incidence and the ratio of you to have a myocardial infarction is increasing. Increasing your systolic blood pressure, there will be increasing trend of your chances to get a myocardial infarction. Okay, similarly also if your another one for microvascular complication, when they're increasing your systolic blood pressure, they will increasing your chances to get a microvascular complication. Microvascular mainly is about your eye, retinopathy, and also your kidney, and also neuropathy, nerve. When your blood pressure increase, the chances adjusted ratio is a bit increasing. Similarly, also another lens, if your diastolic, your diastolic or baseline blood pressure, once is increasing your diastolic blood pressure, the lower end, the blood pressure, you will increase relative risk of to get a stroke, and also relatively risk to got a coronary heart disease. Similar. So if someone asks, which one is important, the diastolic, the lower blood pressure, or is it the higher one, the systolic? Actually, both is important. You have the good control of both of it. Okay, the prevalence of hypertension in our country, in Malaysia, in 2006 until last 5 years, 2015, little bit downward, a bit from 2011, 2015. But if you see that for the 30 years above, the last 5 years, 2015 national survey is about 39 or about 40% prevalence of hypertension in our country. And in last national survey, it mentioned that every 2 be diagnosed patient, there are 3 undiagnosed patients of hypertension. And only about 37.4% of patients on medication achieve the target blood pressure of 140/90. The rest, 60% above, patient with hypertension with medication still not achieve the target. 140 and 90 millimeter mercury. That's based on the prevalence. So what is the definition of this hypertension? Definition of hypertension, high blood pressure is persistent elevation. I to be bold this one, persistent elevation. For example, if you got only one reading, systolic blood pressure on 140 over 90 or greater, or your systolic blood pressure of 140, 140 millimeter or type error 140, or your diastolic blood pressure 90 millimeter or greater, 140 and above, or and with diastolic 90 and above, like this one. If you see for blood pressure omron, this one, the above one is we call a systolic, and the below one is diastolic. Yang bawah ni is heart rate pulse rate. So if your blood pressure above 140 and the below is 90, or either 140 only and bawah is 80 something, you are still a hypertension. But must be a few reading, not just one reading, a few reading, persistent. Okay, how to classify? The optimum, the ideal blood pressure, if you check your blood pressure, should be less than 120, and your diastolic should be less than 80. 120 and 80 below, that's the optimum. But if your blood pressure you check between 120 to 129 is normal, and diastolic is 80 to 84 is still normal. But you become at risk to develop hypertension if your blood pressure above 130 but less than 140, 139, and your diastolic 85 to 89. So prevalence in Malaysia, based on National Average Survey 2015, those who at risk is about 18.6%. And if see about the hypertension, if those who stage 1 mean the blood pressure between 140 to 159, and diastolic is N or 90 to 99 millimeter, and stage 2 is 160 to 179, and diastolic for the stage 2 100 to 109, and stage 3 is above 180, or the diastolic above 110. And a few patients, some they have isolated hypertension, they just have systolic only high, but diastolic is normal. We call as isolated systolic hypertension. Okay, how about if your blood pressure? Sometimes doctors say, okay, blood pressure baru satu reading tinggi, you have a home blood pressure monitoring. Please bring your home blood pressure monitoring for next 1 week. Datang setiap hari, check blood pressure, and then next week jumpa doktor, bawa you punya reading. So the home blood pressure monitoring actually for the stage 1 hypertension, just now for clinic blood pressure is 140/90. For home blood pressure monitoring is about 135 and or diastolic 85. Dia terbit lower sikit. Lower is about 5 millimeter mercury. Stage 1 hypertension. If already 135 and 85, you already stage 1 hypertension. Whereas in stage 2 hypertension, if you can see that the clinic blood pressure 160/100, in the home blood pressure is 150/95. This is based on the guidelines CBG Malaysia hypertension. Okay, don't, if you do your home blood pressure kata, oh, quite okay, my blood pressure 135, 85, not reaching 140/90, actually you already have hypertension based on your home blood pressure monitoring, like just now the Omron. You already hypertensive. Okay. Classification of blood pressure based on average 2 or more reading taken at 2 or more occasions. Sometimes they have isolated office or white hypertension, the BP elevated in the clinic, but normal at times. And some, like mentioned now, isolated hypertension, the systolic pressure is high, 140 and above, and diastolic is less than 90. Okay, once you got hypertension, they will assess either you got the secondary causes, or maybe you have target organ damage and identify other cardiac risk factor. Not all patients we have high blood pressure persistent, we terus start ubat, tapi we check, we assess the condition first. Assessment of secondary cause hypertension, for example, maybe they have sleep apnea, they have drug-induced chronic disease, kidney disease, or endocrine factors, and maybe a few other diseases, coarctation of the aorta, cardiovascular arthritis. And we will screen, we will assess about the major risk factor if the patient have, for example, cigarette smoking, central obesity, inactivity, Dyslipidaemia, diabetes, and the age factors, 55 or in men or disease-fied women. Family history premature cardiovascular disease means that their siblings or the first degree relative or the parents have a heart attack or strokes. Less than 55 in men and less than 65 in women is a family history, a strong major risk factor for the assessment during the assessment. The target organ we will look for the heart problem, we do the ECG for any left ventricular hypertrophy, any symptom of heart failure, for any stroke or TIA symptom before, and chronic disease, check the urine and also the renal function test, and the peripheral artery disease, and also do the funduscopy or the fundus camera, look for the retinopathy. Based on that one, the risk situation, just now the blood pressure. If you're at risk low, you had low risk with no risk factor, you are low. But if you're between, even you have a blood pressure 130 and above, you have a risk factor T or target organ damage, actually you are at the intermediate risk to develop coronary vascular disease. Similarly also, if you are to be higher, your blood pressure, your risk to develop the cardiovascular disease to be higher, medium, high, and very high. And based on that risk, actually the doctor will decide either you will proceed with your lifestyle changes, it means no need to start medication, or they will start with a drug treatment, but must include also lifestyle changes, or those who high and very high for sure, they will start the drug treatment together with lifestyle changes. This algorithm, how we do if you have been managed or you've been diagnosed of hypertension. They will check globally your risk, and after that they will decide if you have a low risk, they will ask you for therapeutic lifestyle changes, is mean non-pharmacological management for 3 to 6 months follow-up. And after they will check again, if your blood pressure more than 140 and or that's more than 90, they start drug treatment. If not, they will continue with a therapeutic lifestyle changes, about 6 months follow-up. Okay, so the screening, if possible, you check blood pressure every opportunity you have, every time you go to the clinic, to whatever reasons, for example, for a cough or for your screening, for anything, check your blood pressure, because high number of nations are undiagnosed of high blood pressure. Check the BP for every adult above age 18 years at least once a year as a part of their annual health screening, or more frequently for those who are at risk. For example, family history, obesity, those who risk of high blood pressure. Okay, that's, I think we have another few more minutes about the management of NCD. I will a bit more faster. In managing of this NCD or diabetes, hypertension, and high cholesterol, mainly it's about lifestyle interventions, about how we modify our diet, or we call it a medical natural therapy, and how actually we do exercise regularly, how you will maintain your ideal weight, and or if you have a more than ideal weight, how you weight loss or weight reduction, you need to avoid or stop smoking, and how your body cycle support stress management. And the other things management, if you're not managing or based on the risk, if you will start on lifestyle intervention, after 3 to 6 months is not controlled, they will start the pharmaco management, or it means the drug management. Okay, for non-pharmaco, for medical natural therapy, or for the diet modification, if possible, for these 3 diseases or chronic disease, or those who still not have the disease, please reduce your calorie diets. You have to reduce your carbohydrate to 45 to 60%, your fat less than 30%, and energy from protein is about 50% high fiber diet, and reduce the sodium intakes. This Malaysian food pyramid, this one is 2010, supposed to be the new one, 2030 will be produced soon. If you see this food pyramid, Malaysian food pyramid, for the adult population in Malaysians, for daily serving size 1,500 to 2,500, we can see that eat more masih ada kat sini, nasi putih, everything, fruits at the second pyramid, and milks and product at the third, and last fats, all everything, eat less. The new one in 2020 soon will be produced. The rice will be changed to up, and the food will be down. In other words, kita galakkan supaya Malaysian population eat more fruits. Bukan 2 serving, is more fruits. Later on they will produce a new one food pyramid, yang bawah, yang fruits ni will be lower, yang rice noodle ni akan naik ke atas. And then they have a specific groups. For example, the food pyramid for the elderly different, the food pyramid for the children different, and the food pyramid for lactating mothers who breastfeeding to be different. This one for general populations. Only the new one will be produced soon by the Ministry of Health. There are some changes on the lowest one. The rice ni probably dikurangkan makan nasi putih. The plate models, which some say bahagikan kepada your pinggan tu, bagi kepada suku-suku. That's why some say that pinggan siap Malaysia, suku makan nasi everything, ikan protein another suku, and half it of your vegetables and also your fruits. That's why they say suku separuh. If you can implement or can practice this, is very good. Okay, that back to diabetes. Try to choose a glycemic index in your diet. Low glycemic index, we lower the GI food, reduce postprandial glucose. We lower GI food, must improve the glycemic control. And in this glycemic index, they have quite numbers of which one. You have to know which one the fruits or your uh, meals that you taken have low GI, which one high GI. For example, the rice, they have few type of rice with low GI, glycemic index, and high GI. For example, white rice for sure is high GI. Possible cuba tukar ataupun kurangkan makan with a white rice. Similar with the others about low GI and high GI. Okay, back to the fats. It has been mentioned just now. The fat should be reduced to 30% of our energy intake of all individuals. And for trans fat, if possible, less than 1% to take. Or try to avoid. Cuma masalah trans fat ni selalu yang kita ambil lah. That's the bit about deep fried food, burger apa semua, or the fast food, all is trans fats. Try to reduce on that one. Reduce as much as possible the trans fats. Saturated fats also similar. You try to reduce. For animal fats, everything try to reduce on that ones. Where the current actually recommendation that to intake of saturated fat should not exceed 10% for your energy intakes. Less than 10%. This one trans fat 1% or below, or tak payah ambil pun terus. And galakkan for unsaturated fats, like polyunsaturated and monounsaturated fats, about the olive oil, everything, you've been recommended for that one. Okay, how to choose the healthier fats? A few sense about good with those fats with omega-3, with saturated fats is good for you. And what's a bad? For example, fried food, everything, try to reduce on that one. Okay, the aims for weight reduction as far possible, aim the ideal BMI. With the Asians, BMI is about 18.5 to 23.5. And try to reduce if your BMI is high, try to reduce within 6 to 12 months, about 5 to 10%. As little of 4.5 kilograms, significant will reduce your blood pressure to 4.5 to 3.2 millimeter mercury. And then to reduce the sodium intake for if you are hypertensive. Healthy eating, just mentioned, try to reduce smoking or stop smoking. Reduce, they will reduce quite a lot of cardiovascular risk, and a bit more related therapy. The therapy generous about yoga, everything. Or maybe for us as Muslim, reading Al-Quran, everything, solat, everything is a part of resting therapy. And that's about the exercise. The exercise, before doing exercise, assessment of medical and physical fitness is depends, is individualized exercise program and appropriate to your age, your physical, social, cultural, and economic status. In general, exercise we can say is structural and non-structural exercise. The structured exercise, if possible, you have to do minimum 150 minutes per week. If you want to reduce your weight, you should increase more until 250 to 300 minutes per week. But for normal one, it's about 150 minutes per week. The type of structured exercise is low, moderate, and high intensity, for example, aerobic exercise. And non-structured exercise is what we want to do every day. Example, 10,000 step, climb step, everything. And try to do all this regularly and avoid any injuries. And if you see from the global recommendation of physical activity for heart WHO, a few suggestions of the physical activity. Before exercise, pre-exercise assessment important. Exercise almost every day if possible, or 5 days a week. And the numbers of exercise about 150 minutes per week. For moderate intensity. For moderate intensity, or we call as structured exercise. And or you can do at least 75 minutes per week of vigorous aerobic exercise. And all this physical exercise, and you also can do at least 2 sessions for resistance exercise, for example, dumbbell, everything. And they will improve your glycemic control, reduce weight, and reduce the cardiovascular disease. So grading of physical activity, they have a few grading: of mild activity, moderate, and strength exercise. For example, mild activity, like just now, golf, bowling is mild. Moderate activity, playing badminton, cycling, faster walking. And strength exercise like jogging is a strength exercise. Swimming is strength exercise. Basketball, everything. Resistance exercise possible about 2 to 3 times per week only. And there's a physical activity pyramid, if possible every day. This one is non-structured exercise, 10,000 steps, walk up the stair, walk to the shop, housework, gardening is every day you have to do. For the structured exercise, this one about 5 to 6 times a week as possible. Cycling, aerobic, playing football, badminton, everything. 2 to times all the strengthening exercise, and try to limit physical inactivity and also stress lifestyle. Similar, this one from the portal Sihat, Ministry of Health. If you are age 18 to 59, this is what you should do. If you are elderly, this is what the bit reduction of that one. And really emphasize on the 10 step per day in every day for your non-structured exercise. Banyakkan berjalan, naik tangga, kemas ruang, berkebun and everything. Okay, if your pharmacological intervention should be considered, medication will start after failure to achieve the target after 3 to 6 months of lifestyle modification. And for the anti-diabetic medication, a lot the doctor will give, they will choose one for 9 or 10 now new lots of anti-diabetic agents. Which one is the best suitable for you? Similar to the hypertension, this common hypertension drug, like the diuretic, beta blocker, CCB, ACE or ARB. And they will choose. Usually the antihypertensive, they need to combine to achieve the target. Based on the latest guideline, once it's not, you want to start medication, with combination is the best. And then for lipid for similar, if still not achieved within 3 to 6 months, we start the medication. Usually we start with the statin, this one, SMG co-reductase inhibitor or statin. That's why they have a few medication with different strengths, atorvastatin, this one simvastatin, rosuvastatin. Some patients with lipid they need one or still not control, sometimes they add on with another group if they have another higher of triglyceride, for example. Okay, last about the target. Please target for your, if you are diabetes, the fasting, this is 4.4 to 6.1. Non-fasting 4.4 to 8. A1C should be less than 5%. And the target for A1C actually individuals depends to the patient's problems. For example, newly diagnosed with a bit tight target, less than 6.5%. And those who less tight, those with comorbidity, for example, coronary disease, those who renal failure and liver function. Same also this one. And for the, if we do the glucometer test for targets for those with GDM, diabetes, chronic pregnancy, for example, if we call as blood sugar profile, in all the pre-meal, if do the glucometer, the pre-meal, the target should be less than 5.3. 1 hour post-prandial should be less than 7.8, and 2 hours post-prandial should be 6.7. Or sometimes 2 hours post-prandial we call it pre-bed. Before bed should be less than 6.7. This is what the target we want for patients who have diabetes, comorbid pregnancy or gestational diabetes. Why actually some doctors really want to see about the A1C? Because A1C is the level of your diabetes control for the past 120 days or about 3 months. For example, if your A1C is about 8%, actually your average of blood pressure is about 10.2 blood glucose. That's why sometimes usually when the average we put the 6.5, we want your blood pressure, your blood glucose about 7 to 8 point something, 8.6 like this one. You will estimate your glucose level for the last 3 months. Okay, for the cholesterol, the target should be 5.2 for the total cholesterol HDL for males. 11, male more than 1, female more than 1.2. The triglycerides should be less than 1.7. LDL cholesterol based on the cardiovascular risk. Those who low, moderate, less than 3. High cardiovascular risk should less than 2.6. Very high risk should be 1.8 and below. Even actually this actually has been changed. Latest from the European Heart Society, actually they are lowest of this one. Those very high, a bit lower than that, but 1.5. But this one Malaysian guideline still follow to the Malaysian guideline is less than 1.8 for very high risk. Okay, for the blood pressure, mainly the blood pressure should be around 40, 80 if you non-diabetes. If you got diabetes, should be lower than 40, 80. Those who have renal impairment is 130, 80. And I think that's all for me. Any questions? Should I stop? Yeah.
Prof, maybe I
Yeah.
can read questions from YouTube. Someone have been asking,
Okay.
how about lamb fat? Some says we can consume lamb fat because it is a good fat. Is it a meat or is
Sorry,
it?
sorry. What the question?
How about lamb fat? Some says we can
Oh,
consume
lamb.
lamb fat.
That's why it depends like lamb fat upon kambing that one like mentioned that one the fat a few trans fat if we try to reduce trans fat lamb fat tu sometimes masuk trans fat together dagings daging merah everything is I try to reduce for example if you want to take that in the guideline they say less than 1% actually 1% tapi try to avoid that one try to avoid
Okay, another question.
the oh have a question kalau okay, one question is say that if we already start on antihypertensive medication, and if your blood pressure is okay or maybe it's controlled, should we stop the medication? So the answer no. Uh, if you've been diagnosed with high blood pressure or hypertension, and your blood pressure become to normal, you become normal because maybe is most really because you already on the antihypertensive. This antihypertensive will lowering your blood pressure, but once if you stop, your blood pressure become back to high. Please do not stop. Unless maybe if you're too low, for example, maybe you already practice healthy lifestyles. You have reduced your diet, exercise. Maybe your blood pressure to be reduced. The doctor will see, and then sometimes maybe they will adjust the medication accordingly. But please don't stop. Don't stop. Sendiri-sendiri nak stop. Tolong. Jangan. Okay. Ada few question more say that some say metformin amlodipine can cause kidney failure after long period of time. Okay, metformin and amlodipine. Metformin is the anti-diabetes medication. Amlodipine is the anti-hypertensive medication. It's a calcium channel blocker. Metformin actually is the first line anti-diabetic medication or agent that we give to all patient diabetes, unless patient have a side effect or maybe patient don't tolerate, maybe we change or maybe with the other medication. But metformin not actually cause the kidney failure, but the diabetes itself is not control actually cause the kidney failure. Cuma sometimes we will adjust the dose accordingly. That's why monitoring of your diabetes is very important. Monitoring this means we do a few tests including the kidney functions. If your kidney function a bit impaired because or maybe ada some reduction, your we call a glomerular filtration rate (EGFR) function is reduced, the doctor will adjust your metformin level. Metformin. Maybe previously you take 1,000 milligram, ataupun their doctor will reduce. For example, if you're the CKD stage 3B or 4, maybe they will reduce to half dose. But not metformin directly cause the heart failure. Similar with amlodipine. There's no actually study say that amlodipine can cause the heart failure. No, that's wrong. Okay, any question more? Uh, okay. Okay, I think that's a question. No. Okay. Any questions? This one, maybe I not discuss about the medications, because medication maybe some what type of medication you want to use, which one the best based on the latest evidence, that one will be another platforms, But I suggest for the next, if possible, to share a new about the food pyramid. That one maybe we can invite our dietitians in the Kulliyyah Health Science to discuss about the new food pyramid soon will be produced, and about the ideals about the foods and modifications. It's good actually for benefit for all of us. Okay, I think give back to the chairpersons.
Okay, thank you very much, Prof, for this sharing today, and also for the ideas to counter these diseases. I think afterwards we can change what's on our plate, and maybe we can change our exercise sets accordingly lah. So everyone, if you missed out the tips, you can always rewatch at our YouTube channel. And some of them have been requesting your slides, Prof. Is it okay? Okay, if it's okay, then maybe you can email to me and we will put it up in our Facebook.
Yeah,
Facebook.
we made to you.
Okay, so Alhamdulillah, we have come towards today's end of the session. Hopefully, we could benefit from this session and apply the takeaways in the future, inshallah. So, as Prof suggested, I think maybe we could invite speakers to discuss about the modified pyramid diets. Okay, thank you so much, Prof. Assalamualaikum warahmatullahi wabarakatuh. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Thank you, everyone, and thank you, Prof, again. Inshallah.
وعليكم السلام ورحمة الله